chronic. It's inflammatory disease that causes ulceration of the mucosa in the GI. It's common, most common in those 20 to 40 years of age, so not an older person. And I don't know why, and I couldn't exactly figure out when I researched this what the reason was, but they say that Anasazi Jews have a higher incident of irritable bowel disease, specifically ulcerative colitis, and I don't know what that genetic component is. Suggested causes are infection, anticolon antibodies, dietary, genetics. Mostly it's genetics. These are irritable bowel syndromes are genetic in nature, meaning that you get it from your family member for the genes. Now this is very different than Crohn's is ulcerative colitis, and that's why I put the word continuous in here. Lesions are continuous with no skipped lesions, are limited to the mucosa and are not transmural. So let's understand what that means. So lesions are continuous, meaning it's throughout the entire GI. Okay? There's no skipped lesions. Skipped lesions are, there's a lesion, skip, there's a lesion, like in Crohn's, skip, there's a lesion, skip. This is continuous. They're not transmural with ulcerative colitis. What does transmural mean? Transmural means that it's going through the entire thickness of the mucosa and causing like a hole. Crohn's disease often will have that. So this is different. It's not transmural. So it doesn't go completely through the tube. Clinical manifestations are going to look like diarrhea, bloody stools, cramps, remission, and exacerbation. Because it's an inflammatory disease and there's no cure for it, we can just manage the symptoms when they're here and then hope that they go away and go into remission for a longer period of time. So this is something that flares up. And you'll hear people that say IBD, they'll say my IBD is flaring up. You know, that's what they mean. Diagnostic tests are colonoscopy is the most definitive test because that can see all of the lesions. First line therapy is a medicine called mescalazine, steroids, and aspirin. Solicitate is aspirin, and we're going to not give that, but we're going to give steroids. Steroids will reduce inflammation, remember? And this is an inflammatory disease, so we tend to treat the inflammatory diseases with a steroid. Immunosuppressive agents, because this is considered a little bit autoimmune. In other words, what is going to reduce the inflammation? We're going to give a steroid, we're going to give immunosuppressive agents. Broad spectrum antibiotics if there's an infection abroad. Surgery, resection of the colon or colostomy. So they might decide to take an extremely diseased part of the GI out and then put a colostomy bag there. And you've probably seen those in the hospital where the colostomy bag, what we call an appliance, is attached to the patient and the stool is going into the bag. I know those nurses are making you empty it. You know they do that. They think I'm stupid when I come out to clinical. Like, quit giving all the bad work, the work that you don't like, to the nursing student. You should see me in clinical. I'm something else. I get in their face so fast. Yes.
I had a patient on Tuesday with history of ulcerative colitis. He presented to this hospital with acne and something else. I was like, okay. The thing is, when he came in, there were so many ulcers on his body that were this big,
Oh my
all
God.
crusted, and like had pus and like dried blood. Like when I say everywhere, it was like scaly skin everywhere.
That sounds like he has another process going on.
So I looked it up. I was trying to figure out what I forgot what it's called, but because he said he had stiff neck too. We're like,
Oh no, so you were worried about meningitis,
yeah,
right?
but I'm assuming at this other hospital he was cleared for that because he went home said no to the prednisone and got discharged antibiotics, then the ulcers got painful, I think. So we went to Stanford, but then, essentially they treated him with antivirals, but that triggered some kind of autoimmune reaction with like ulcerative
Oh, that's
colitis.
what,
So he just like broke out and he was like, when I
So
say
he's
like
having a
ulcers
reaction.
everywhere, ulcers were like
Oh.
everywhere.
oh, that sounds so painful for him.
Yeah, it was not pretty.
Yeah, we need to get pain meds. Yes.
For the mesalazine, is sulfasalazine also the same line?
Yes, yeah, all the ones that end in INE. Oh, you guys ask really good questions. Crohn's disease is the other IBD. It's also inflammation and ulceration of the GI tract. It tends to be with regional enteritis, in other words, all over and kind of global in the stomach and in the GI, the pain will be. Idiopathic, we're not quite sure. We know it's genetic in nature, but we're not quite sure what's causing it. It also has remissions and exacerbations. It affects any part of the GI tract from mouth to anus. And that's a lot. Difficult to differentiate between ulcerative colitis, similar risk factors and theories of causation, strong association with gene mutations. But with Crohn's, we have those skipped lesions that we were talking about. So we'll skip on the lesions, not continuous like ulcerative colitis has continuous. This ones are skipped. Produces a cobblestone appearance. So they'll also call it, the skipped lesions will cause a cobblestone appearance if on camera. It's not like you can look at the patient and see what's going on inside, but on these endoscopies and colonoscopies, they can tell a lot, and they say it's got a cobblestone appearance, and we know it's associated with Crohn's. Abdominal pain and diarrhea are the most common signs, more than 5 stools per day. Treatment is similar to ulcerative colitis. Are we gonna bleed out? We could, right? So with a GI bleed, this can be GI bleeding. So the treatment is similar to ulcerative colitis in the sense that we're gonna give the steroid therapy and the therapy that decreases inflammation. There is something on the market called tumor necrosis factor, or TNF, blocking agents. It's to treat the fistula because they think that it's the same idea of cancer eating through the GI system. It's the same idea as the Crohn's. It's just eating itself through. All the ulcers are eating through and causing transmural. So with the Crohn's, this can very well be transmural, which means it goes all the way through the thickness of the GI mucosa. I can tell you my son has Crohn's for 10 years now, and he's been close to death in the hospital where they're giving him TPN and lipids. But how we found out he had it, we kept bringing him back that something's wrong with my son, even though he's an adult, I know that something's wrong. And what I noticed was, I didn't want to hurt his feelings, but what I noticed about it was that he had very bad breath. And I told the doctor that, and the doctor looked in his mouth and he said, yeah, he's got lesions in his mouth. So that was the beginning, and that's why I know this Crohn's can go from mouth to anus easily. He's also had an appendicitis as a result. We dealt with that. But this is, it's serious business. So what we do with Crohn's disease and with ulcerative colitis is, if we're gonna give immunosuppressive agents, it has to go in IV. This is not the kind of patient that's gonna take a pill every morning. So it goes in usually every 6 to 8 weeks. The patient, for the rest of their lives, every 6 to 8 weeks, will go to the outpatient and sit there for like 3 or 4 hours while they infuse this medication. And that's the only way to suppress. The problem with those medicines is they cause, being that they're suppressing the immune response, they can also cause the patient to be immunologically deficited. In other words, they get infections very easily. immunocompromised.
I have a question.
Yes,
Did you say it was the tumor necrosis factor alpha? That was the one that they go every 6 to 8 weeks
No.
to use? Which one is that?
no, the one that they go the ones that they're using right now, because what happens, you guys, is these medicines come out, they're working great, and then the patient becomes resistant to it. And then so they have to come up with something else, and right now they're working on one that's called Entyvio. That's the one on the commercial on TV. Remember the song, Entyvio, Entyvio, Entyvio? That's the latest and greatest. That's why they advertise it so much, because this area of medicine is changing so often, because the patients are immunocompromised, and then they're becoming resistant to their own med. Nina?
So that's the immunomodality agents that you're talking
Yes.
about, that they come in every 6 to 8 weeks.
Yeah, to get infusion,
Okay.
exactly.
So the TNF alpha, that one is PO, they would take that by mouth.
No, that one also can go IV,
Okay.
yeah. This is a nice little chart for you. If you learn nothing else from these slides, you can just look here. Because this is where your test questions are gonna come from. La-di-da. Yes, do you have to know all this detail? No. Okay, a nurse is reviewing the lab data of a client who has an acute exacerbation of Crohn's disease. Which of the following blood lab results should the nurse expect to be elevated? So not decreased, but elevated. ESR, who said ESR? How did you know that, Nina? That's
We
right.
were learning that CRP and ESR are lab values that indicate inflammation.
Yes, oh, good for you, yeah, okay. Did you learn that in your PEDS class?
We had to
I
learn
like it,
ourselves.
yeah. I like it, yes, so ESR will be elevated. She's teaching you a lot.
No.
I'm trying to get it down.
Yeah, it's me.
Which type? No, you guys were gonna be nice. Which type of bowel disease is most likely to cause severe malnourishment? It's actually both of them. It's actually both. Yeah, that's why there's only 2 answers. I know. I could have made up other stuff. Which medications are used in the treatment of Crohn's disease and ulcerative colitis? Well, we know the salicylates are corticosteroids, because steroids are immunosuppressive, and immunosuppressives, yeah. That one was kind of hard, huh? Harder. What does EFR stand for? Yes, yes. That's right. Now let's switch gears and talk about liver for a little while, then we're done with you guys, and then we'll talk about the diarrhea. A lot of this we got already.
So that other lecture is not important?
No,
Okay.
it's repetitive.
Okay.
Yeah, it's repetitive. But we didn't talk about hepatic dysfunction. But we talked about it with our case study. So this is what the normal, just what the regular little liver looks like. You can see it's kind of close to the aorta, and it's got its own hepatic vein. So what are the functions of the liver? Is immunity. It helps us stay immune with our Kupffer cells. It stores fat-soluble vitamins for us and minerals. It detoxifies things like hormones and drugs. It synthesizes serum proteins, clotting factors. That's why patients with liver disease bleed, because they don't have the clotting factors that they should. Phospholipids and cholesterol, it makes all that. So if the liver is making that and it's not doing a good job, you're gonna have deficit problems. Metabolic, glycogen fat storage, it helps us metabolize our items here, especially ketone. secretory, bile, bilirubin conjugation, and cholesterol removal. So it secretes the bile that we make for our bodies to digest our food. It's secreted from the liver. And so it kind of has a lot of function, right? Vascular reservoir. It holds 1 liter volume and it can expand and compress. Jaundice is what happens when there's too much bilirubin backed up into the liver. And now it's not draining via the common bile duct. It's not doing it anymore. And so I don't want you to get too, there are different kinds of cirrhosis. It's prehepatic, intrahepatic, and posthepatic jaundice. But you don't have to know this very thing. Just know what jaundice looks like. What does jaundice look like? Yellow, right. Right? With cirrhosis, it's going to be diffuse scarring all over the liver. And you can see this one is pretty well cirrhosed. Remember the smooth one we just saw? And it's got like that, almost like a cobblestone liver. Destruction of hepatocytes, so the liver cells in cirrhosis are dying. It's chronic and progressive. If it's caused by alcohol-induced, we call it Laennec cirrhosis. Post-necrotic cirrhosis is hepatitis, would be an example, hepatitis infection. Biliary cirrhosis, an example is obstruction. So this is if there's an obstruction and then we have bile stasis because it's not draining anymore. This is going to cause jaundice. Cardiac, right-sided heart failure causes vascular congestion, which can lead up to cirrhosis. Early symptomology looks like generalized weakness with weight loss, anorexia, nausea and vomiting, and flatulence, which just means passing gas. Later symptoms are jaundice. So jaundice is not an early sign, right? If you see jaundice in your patient, this liver disease has been hanging around for a while because it takes more than a minute to develop jaundice. So later signs are going to be jaundice, ascites, coagulopathy, and bruising. So the blood is either clotting too much or it's bleeding. All body systems are affected: neuro, GI, renal, cardiovascular, pulmonary systems, endocrine, hematological, and dermatological. Patients that have cirrhosis are sick patients. They're very sick patients and we need to take very good care of them. This is where their early manifestations are going to be that general malaise and that discomfort we talked about. So right up here in the right upper quadrant is where the liver is located. So that makes sense that the patient would have pain there. Later clinical manifestations are going to look like our little cartoon here. Notice this one, I've seen this a lot, spider angiomas on the face, neck, and shoulders. This is pretty cardinal of the cirrhosis patient. Ascites, gross generalized edema in the stomach. So that's going to cause ascites. And what can we do to take care of the fluid in the stomach? What does the doctor do sometimes? Yeah, drain it with a peritoneal drain. Yeah. Cirrhosis complications are going to be portal hypertension, because remember the liver has its own system there for cardiovasculature, has its own system, but this is portal hypertension. It's hypertension within the organ itself. Ascites, encephalopathy. Encephalopathy occurs because ammonia is not being detoxified. And remember that ammonia is one of the cardinal, it's one of the largest component of your urine. So that's where this hepatorenal syndrome comes in. It's affecting the renal and the liver, and what happens is the ammonia level is not drained out via the urine, so it stays in the bloodstream, and it's toxic. The patient that's liver sick, often we will say the patient is toxic. Yes, Nina?
How are you measuring the portal hypertension? Like, how would you know somebody has that?
Doctor will do that. Doctor will do that, and they usually can tell by looking at the x-ray. They can tell what's under pressure. That's a really good question. So we're not, we're looking for that in the chart though. Because if I want to know if my patient has it, you know what I mean? Yeah. This is pretty cardinal hepatic encephalopathy from too much ammonia, and what it causes the patient to do is get very twitchy. They twitch their muscles and they get very confused and somnolent. It can be a very sleepy time for them, and then when they wake up, they're very confused. They don't know where they are. I mean, it presents like dementia, but it's not. It's just from the ammonia. And the wonderful thing about that part, as soon as you clear the ammonia, the patient looks at you with a straight face and says, "What's going on? I don't remember anything that's happened over the past few hours. We just pulled all this ammonia off you." If they're a chronic liver patient, they know they went through that process. What is the name of the medicine that we give to clear the lactulose? Oh! I'm stupid, I gave you the answer. Yes, it's called lactulose. And it causes diarrhea, and that's how the ammonia leaves, is vis-a-vis the diarrhea. It causes soft stools, frequent soft stools and diarrhea, but that's okay, we're expected. It's not a side effect, it's an expected therapeutic effect. That's how we get rid of all the ammonia. And then we have ascites. Signs and symptoms of ascites are going to be bulging flanks. Remember, if it's in red, you're probably going to see it again. Protruding umbilicus, and doesn't that make sense? Everything is big from all the fluid. A fluid wave to palpate, shifting dullness. This just means, oh, I think I have a picture in here, yeah. So the dullness is going to be where the gravity is. So with fluid, when you're percussing fluid, it's going to be dull when there's a lot of fluid in there because of the consolidation. Remember when we talked about the lungs and we were doing it? Same thing, there's fluid in here, and it's going to be dull where the fluid is sitting, and it's going to be tympany, that higher pitched noise that you make with your percussing, because it's full of air. So air is tympany, and dullness and fluid is causing the percussion to be dull. And see, this person's laying a certain way, and then this person's laying on their back, so that's why it's coming down. And that is a model of a liver. So ascites treatment is that we want to support the airway. If they're not breathing because of too much fluid, we have to deal with that. We do mobility impairment. It's hard for them to move. You saw all the feet on my other picture. It's very swollen. Sodium restrictions, diuretics, and paracentesis. Paracentesis is the name for tapping, or what we do when we put the needle in the, doctor puts the needle in the patient in the peritoneal cavity and drains it all out. You will be assisting with that procedure. You're going to be assisting. And I got news for you, being that they have encephalopathy, the doctor never likes to give anything to sedate. So we're not allowed to sedate the patient. But normally it does hurt, when the needle goes in, it does hurt, but my experience with the patient is the first prick, hurts when they first put it in, but then they're so relieved by the water coming off, they forgot about that. They forgot about the needle, because this can be very therapeutic for a patient. Wait till you see how big they get. I've seen men that look like they're about to deliver quadruplets. I mean, it's really, really uncomfortable. So the sodium keeps the water off, diuretics keeps the water off, paracentesis. We also give albumin, IV colloids like albumin. And also there's something called a TIPS procedure. If the patient has too much portal hypertension and we're not able to control it and the patient is very uncomfortable, they'll do a TIPS procedure, which is pretty much they'll put a shunt in. Trans-intraportal shunt. That's what that stands for. Intrahepatic shunt. And it's just like a bypass operation, but they just put a shunt in to shunt all the fluid off. And this is supposed to be the drape. Why did they put a see-through drape over it? I guess just to show you that it was coming out, but paracentesis is the removal of that fluid. That's what it looks like. tapped by the doctor. Watch out for hypovolemia. Excuse me. These patients, if we pull off too much fluid, they're gonna have a hypovolemic situation. In which case, they're gonna have, what can it do to the blood pressure? What do you think? It's gonna cause the blood pressure to go down really far. That's how you'll know. Because if you're helping with this procedure at the bedside with the doctor, you're gonna have your patient on an automatic blood pressure cuff that's going off every few minutes. So that's one way you can do it, and that's the main way to do it. Okay, you don't need lactulose, we talked about, lactulose can be given PO, and it's, comes in a syrup form, and we give 30 mLs. Either that, or we can put it in the NG tube, and that can work, or we can also give it by enema. The lactulose enema is the reason my daughter doesn't want to be a nurse. I brought her to work night one night. Can you believe they used to have to bring your daughter to work night in CCU? But they did. She was about to go to college. This was years ago. She's in her almost 40 now. And she was about to she wanted to go to nursing school, so she thought. She said, can I come with you and your friends from nursing school? Because I was hired with all my buddies. Here we are at Stanford. She comes in for a night shift. In the morning, she just looked at me. We had a patient that had a lot of enemas, lactulose enemas. She wasn't seen. She wasn't coming in the room and violating the patient, but she was like aware that we were doing it, me and my friends, and who I also went to nursing school with. And we start walking out in the morning after the shift is over, and she said, Mom, will you be upset if I don't become a nurse? And I said, no, I want you to become what you want to be. It's right for me, it might not be right for you. And my girlfriend, who I've known for years and knew my daughter of mine when she was in my stomach, we walked out together with her, and I said to my daughter, just so I'm clear, what was it about last night that changed your mind? And she just looked at me and said, the smell. And me and Sarah, my friend, looked at her and said, what do you think we said? Experienced nurse. What smell? Exactly what I said. What smell? We both said, what smell? Yeah. She's not a nurse today. She's not a nurse. She couldn't stand the smell. I'm glad she would. I mean, she didn't know how to turn it off. We know how to turn it off. It's like, what smell? We know how to turn it off. We kind of hold our nose up here. You know the drill. I'm not preaching. I'm preaching to the choir here. Okay, so lactulose, and then there's a medicine that we can give to destroy the antibiotics. To destroy the bacteria. I know, I'm not talking today too good. Neomycin sulfate and rifampicin. We give those two medicines, IV. There's just a picture of what the shunt looks like. It's shunting vis-a-vis the hepatic vein. What if all goes wrong and we now need a transplant? This is what we do. So, criteria for a liver transplant is the following. You need written criteria established at each center with nationwide standards. What does that mean? That some of the liver, for some reason, is a different sort of organ transplantation in the sense that these different centers and different hospitals can make their own rules. So I know what the rules at Stanford are. I might not understand the rules at UCSF. Okay? End-stage organ failure has to be present, so this means end-stage liver disease. Short life expectancy. This is if the doctor says, look, this person can't live much longer like this. Severe functional disability, no other serious health problems, and that's so they can receive the organ without difficulties. Psychological readiness. Psychological readiness because they're going to be on steroids for the rest of their life. If they're not on steroids, they're going to lose the organ because the organ is going to reject. So we have to be careful. No malignancies. If they have other cancers or something in an adjacent organ, they don't want to do a transplant. You are not considered, patient will not be considered for liver transplant if there's advanced sequela of liver disease, things like the esophageal varices, hepatorenal syndrome, so now the kidneys are involved, systemic conditions like sepsis, CVS, diabetes. I mean, they don't want to transplant the diabetic patient. Severe hypertension, intellectual limitations, psychosocial instability. I have a problem with this one ethically, because that's saying that the mentally ill patient can't get a liver transplant. But the reason is they're worried that they're not going to be able to stick to the regimen that is to keep the liver in. It's really hard. But ethically, I don't feel so good about that. But that's just the me thing. Active alcoholism. You cannot be drinking and receive a liver transplant. What I have seen is somebody that got off alcohol, got their liver transplant, and then started drinking with the new liver, and then came back for another transplant. I saw that at Stanford. I'm not kidding you. Yeah, and you should have seen the nurses. I mean, I was taking care of them, but a lot of the nurses were like, I don't want to take care of them. I'm pissed. Like, you can't get like that with patients. It is what it is. You know what I mean? We have no control over what they do. We're just there to take care of them while they're in our care. So, okay. The donor can be deceased or living. Some people will transplant a part of their liver to someone else, like in their family. And the liver is one of those organs where you can live with the liver if it's just one of the lobes. And so they can cut a piece of the liver out of one person and transplant that into the person that needs the liver, and that liver will grow. That liver will grow, and hopefully the patient will do well. Orthotopic just means that they're coming from another portion of the body. They're coming in and they're cutting. Remember, you know what they do this one a lot is laparoscopic. Remember when we talked about OR and we talked about laparoscopic surgery? It's a very large organ with a rich blood supply, so there's risk of bleeding. The risk for bleeding is huge after a liver transplant. Lifelong immunosuppressive medications, forever they're on those meds. And of course, we want to make sure that there's no rejection risk because they're taking steroids. Liver transplant aftercare, bleeding, this is the one I want you to remember. Bleeding, as I said, is number one. Rejection and infection. That's what we're worried about after the liver transplantation, because that's what presents. Have you guys taken care of an alcoholic patient yet with liver disease? Yeah, you probably know about this. This is not that weird. So we use CWA in the hospital, right? We'll use our CWA. Just know that the liver is causing it, right? Because the alcohol is causing it. Anybody that drinks too much is eventually going to get something wrong with their liver. And this is why you will see these men present with things like hepatitis or liver disease in their 40s or so, and they'll say, oh, but I've been drinking my whole life. And I've been drinking since I was a teenager. You'll see it. Hepatitis is a flu-like malaise, fatigue, headache, malaise. This is an infection. So hepatitis is an infection of the liver. It causes anorexia, nausea, vomiting, diarrhea, low-grade fever, cough, an aversion to odors, avoidance of protein foods because they say that it hurts more, elevated liver function test. That's how we can test if the liver is okay or not. We do an enzyme test. It's called liver function, but it's really just looking for the liver enzyme. Severe cases of hepatitis will cause a rash, and arthritis, and painful joints. So we'll have with hepatitis, elevated liver function tests, jaundice, it causes jaundice, dark urine, light-colored stools, or you may see it on a future test as clay-colored stools. I remember being a nursing student and answering a question like that, and I didn't know what it meant, and so I approached the teacher, I said, what does that mean, clay-colored stool? And she said, you should have been paying attention. And she didn't answer me, and I don't know whether I got that question right or not. I still remember the anxiety of her treating me like garbage, you know? Isn't that weird? You guys are gonna remember that I'm so mean.
No.
I remember her, she was mean. But clay-colored stool, because clay is like a white, or like a light, off-white. Tender enlarged liver, severe pruritus, which is an ammonia buildup on the skin. And this is what the patient with hepatitis was. There's the clay-colored stool. I know, when I first saw this picture, I thought it was egg yolks. I know, right? But it isn't. This is urine over here, which is dark, right? You get too much bilirubin. This and jaundice. And this one over here is the urine that's dark with the clay-colored stool on top. And then the sclera will also be an area where you will see the jaundice. Especially if the patient is African American, it's easier for us to see these things if we look at the sclera. It will show. The convalescence for hepatitis last week's, gradual decrease in symptoms, liver function tests will slowly return to normal, serum antibody levels rise, 95% of patients will recover completely. That's a lot. That's a lot of people that have lived through hepatitis, so it's self-limiting. With the focus of care, you want to manage the progression, watching jaundice, stool and urine. Monitor of destabilization, so we don't want the patient to become encephalopathic with ascites, hemorrhage, all those liver symptoms we want to avoid as much as possible. Monitor or manage fatigue and their skin integrity. Monitor labs for wellness and knowledge deficit. Self-care, how it's transmitted, and prevention. Abnormal labs and liver dysfunction are going to be your AST, ALT, LDH, alkaline phosphatase. It's too much for you. You don't have to memorize this, okay? This is like heavy Medsurge stuff. Just know that the liver enzymes are going to be elevated when the patient has liver disease. That's the most that you'll need to know right now. Yeah, elevated serum ammonia, like we said. Oh, why is the prolonged PT and INR?
Do you think it's around vitamin K?
Yeah, because they don't have the clotting factors, right? So they don't have clotting factors as much as they should. So with hepatic, just round your patients and make sure you're looking at them. If they're getting encephalopathic, these liver patients, you're gonna find them have taken their clothes off and they're dangerously walking down the hallway and they're like trying to look for a pole to hold on to. I mean, it's really a risk for falling, risk for bleeding because they don't have the clot factors. So this are the things we're looking at. Just a couple of questions. A client with portal hypertension has been admitted to the medical floor. The nurse should prioritize what assessments? Assessment of BP and assessment for headaches and visual changes. Assessments for signs and symptoms of venous thromboembolism. Daily weights and abdominal girth measurement. Blood glucose monitoring Q4. So it's C. Because they're going to be holding on to fluids with the daily weight. A client who has undergone liver transplantation is ready to be discharged home. Which outcome of health education should the nurse prioritize? So this already had a transplant. The client will obtain measurement of drainage from the T-tube. No, the T-tube needs to be out before they go home. The client will exercise 3 times a week. Not necessarily. The client will take immunosuppressive agents as required? Yes, for sure. The client will monitor for signs of liver dysfunction. Yeah, I think that that's a good one, but C is the best answer, isn't it? Yeah, because that's what's going to prevent the problems if they take those immunosuppressive drugs. A client has developed hepatic encephalopathy secondary to cirrhosis and is receiving care on the medical unit. The client's current medication regimen includes lactulose 4 times daily. What desired outcome should the nurse relate to this pharmacological intervention? So what will be the desired outcome? So it's the same as the therapeutic effect. 2 to 3 soft bowel movements daily. Yeah, I wanna see that, or more. Significant increase in appetite and food intake, no. Absence of nausea and vomiting, the lactulose really doesn't take care of that. Absence of blood or mucus in the stool. That would be nice, but this is why we give lactulose. Just always refer back to what the question is actually asking you, because I know they can be tricky. A nurse is caring for a client with a blocked bile duct from a tumor. Remember, it's from the gallbladder that the common bile duct will drain the bile after the liver has synthesized it. What manifestation of obstructive jaundice should the nurse anticipate? B. Orange and foamy urine. Because that's the bilirubin in it. And that is back here in that, there we are. They're trying to show you the foam on the edge. It's not a very good picture, it's kind of gross after lunch. But what can I say, we have this class after 12:30. I have to show you this. When you're a nurse, you'll be able to eat lunch in the break room and then wash your hands, come back out to work like it's nothing, okay? It's gonna be nothing, because you don't smell anything when you turn the nose off too. But you can't close your eyes. But you can try to unsee things on the way home. You need to unsee that. You don't wanna see that. Okay. I feel like this has been a lot of talking, and it's 2:30. Why don't we, okay, let's do our, cause I had totally forgotten about GI. If it weren't for you guys keeping me on my toes, I really appreciate it. Yeah. Were you offended that I forgot? No, cause I feel bad when I forget things. My kids make fun of me, they're like, you forgot everything. I don't mean to. Okay, so this, for next week, we'll do our cardiology next week. See, because we don't have, remember we have our extra day? We have our extra, but we'll do we're gonna do our CHF, I've a lot of time for it, it's 2:30. We're gonna do our CHF, case study that you guys have to present. I'm just saying for my lecture, I'll do it on week 12. I'll do CHF and then we're gonna do all this. Does it sound fair? Yeah. You're not gonna be questioned on the exam if you're worried about it. I'm not gonna question you on strips. I'm not gonna put a cardiac strip on there. It's unfair to you, you're learning it too quickly, it's not good. And, but I'm gonna teach you about strips. I'm gonna teach you what to look for, because probably when you take your NCLEX, you're gonna have to know the EKG recognition. I'm so pleased that you're taking another Medsurge class next year, because I think that this is gonna make it easier. The fact that you've had a lot of exposure in here, and then next year when you take it, yeah, it's a 400 class. It must be, is it 500? Where do you go after you're done with this? Do you go to, is there a 500 series at San Francisco State? Because you're already in 420, that's why. Yeah, that's what Dr. Kwong said. She said they're taking another heavy Medsurge class. I know, I left the word heavy out originally. I didn't want to scare you guys. But don't be scared. If they don't have a teacher, I'll teach it. I don't know. Yes, I already told her I'll teach anything. This is what I told her. And she invited me to work next spring. And I said, yes, how? I will do anything you want. And that's what I told her. I said, I'm wide open. I'll teach any day of the week, any subject you want. And I left it at that. So Dr. Musselman is making some sort of recipe for me for this spring. Oh, I love it. Yeah, maybe you guys are gonna be, what are you studying after this? Advanced Medsurge?
Yeah.
Yeah. Well, if they don't have a teacher, I'm more than willing to teach it. Yes. Because when we get so involved in this stuff, don't we love it? I know, it's so much fun. Isn't it fun to learn indeed. But I just think it's fun because you guys are gonna get to use it in your real practice. This is about practice. Okay, so we'll talk about cardiology next week. Let's do our presentation. Did you guys email me the presentation, or it's okay if you didn't? Yes.